Hey everyone, welcome back to the channel. Today we're diving into one of the most important topics in cardiology, heart failure. Heart failure isn't just a weak heart, it's a complex clinical syndrome where the heart can't pump enough blood to meet the body's needs. This leads to congestion, low perfusion, and a wide spectrum of symptoms that we will break down step by step. In this video, we will cover what heart failure actually means, the differences between heart failure reduced ejection fraction and heart failure preserved ejection fraction, the key clinical features, and finally, the evidence based treatments that improve survival. Let's begin. So, what exactly is heart failure? Heart failure is a clinical syndrome where the heart's pumping ability is impaired. Because the pump isn't working efficiently, two major problems occur at the same time: congestion and low perfusion. In other words, fluid backs up into the lungs and tissues while the organs don't receive enough blood flow. Clinically, patients present with symptoms like dyspnea, orthopnea, and generalized fatigue. When you examine them, you will notice objective signs such as an S3 heart sound, crackles in the lungs, jugular venous distension, and pitting edema in the legs. These findings reflect the underlying hemodynamic stress. Now, heart failure is not a single condition. We divide it into two major types: heart failure with reduced ejection fraction, where contractility is impaired; heart failure with preserved ejection fraction, where the problem is reduced compliance and impaired filling. You can see both patterns illustrated on the right side of the slide. So we divided heart failure into two types: heart failure with reduced ejection fraction. Here, the main problem is reduced contractility. The ventricle can't squeeze properly, so stroke volume drops and the ejection fraction falls. Because the heart isn't pumping forward effectively, end-diastolic volume increases. The ventricles become dilated and overloaded with blood. The most common causes of heart failure with reduced ejection fraction are ischemic injury, like a myocardial infarction and dilated cardiomyopathy. Anything that weakens the myocardium can lead to this pattern. On the other side, we have heart failure with preserved ejection fraction. In this case, the problem is not pumping, it's filling. The ventricle becomes stiff due to decreased compliance, meaning it can no longer relax properly because it can't fill easily. End-diastolic pressure rises even though the ejection fraction stays normal. The most common cause is long-standing left ventricular hypertrophy, often from chronic hypertension. Now let's look at the classic symptoms of left-sided heart failure, which are primarily related to congestion in the lungs. First, orthopnea. When the patient lies flat, venous blood from the lower body returns to the chest more easily. Because the filling left ventricle can't handle this sudden increase in payload, fluid backs up into the lungs, making breathing uncomfortable. That's why patients prefer to sleep upright or use multiple pillows. Second, we have paroxysmal nocturnal dyspnea or PND. This is a dramatic awakening from sleep with severe shortness of breath. During the night, fluid that was pooled in the leg shifts back into circulation, increasing pulmonary pressures and causing sudden respiratory distress. Third, pulmonary edema. As pulmonary venous pressure rises, fluid begins to translate into the alveoli. This leads to crackles and auscultation. And finally, we have heart failure cells. These are hemosiderin-laden macrophages found in the lungs. They appear because chronic congestion causes red blood cells to leak into the alveoli, where they are phagocytosed by macrophages. Finding heart failure cells is a classic sign of long-standing left-sided failure. Now let's move to right-sided heart failure. Unlike left-sided failure, which leads to lung congestion, right-sided failure causes systemic venous congestion, meaning the whole blood becomes backed up with fluid. First, congestive hepatomegaly. When venous blood cannot return effectively to the right atrium, it backs up into the liver. This causes the liver to become enlarged, tendered, and congested. Over time, chronic congestion leads to what we call anatomic liver, named for its mottled appearance and gross pathology. In very severe cases, this can even progress to cardiac cirrhosis. Second, jugular venous distension. The jugular veins serve as a window into right atrial pressure. When right-sided pressure rises, the veins become visibly distended. Jugular venous distension is one of the most important physical exam clues for diagnosing right heart failure. Third, peripheral edema. Because venous pressure increases throughout the body, fluid begins to leak into the interstitial space, especially in the gravity-dependent areas like legs and ankles. This results in pitting edema, which is often the symptom patients first notice. Heart failure treatment is divided into two groups: drugs that reduce mortality and drugs that provide symptom relief. For mortality reduction, we use angiotensin converting enzyme inhibitors, angiotensin receptor blockers, angiotensin receptor neprilysin inhibitors, beta blockers, aldosterone antagonists, and sodium glucose cotransporter 2 inhibitors. For symptom relief, we use loop diuretics, thiazide diuretics, and the combination of hydralazine with nitrates when angiotensin converting enzyme inhibitors or angiotensin receptor blockers are untolerated. So, in summary, the first group improves survival, the second group improves comfort. Thanks for watching. If this video intrigued you, don't forget to like, subscribe, and join me next time as we uncover more mysteries of medicine. See you next time.